இதோட காமிங்க.
Okay.
Sorry.
So shall we start, sir?
Yes, sir.
Good afternoon. On behalf of the IAP, I am pleased to welcome all of you, those who are present here and those who are viewing this PG webcast. This webcast, which went on for nearly a year, had a break for about few months, and we are restarting it. Thanks to the scientific, the educational grant from OCAD Vaccines, we are restarting the webcast again. Last week they restarted it in Mumbai, and this week we are doing it in Kanchi, Kamakoti Children's Hospital. And this webcast, this session is being carried other than Professor V.S. Shankaranarayanan, pediatric gastroenterologist, and a person who has dedicated himself to pediatric teaching. I don't have to introduce him to anybody across the country in pediatrics. And the case discussion will be carried out by Professor V.S. Shankaranarayanan with Dr. Anish, DNB, final year PG. And thank you. Over to Professor Shankaranarayanan.
Good evening to one and all. I am thankful to the IAP Scientific Committee for the webcast program. Thankful to Dr. SBS, who is the backbone behind almost all the CME programs in the country. And without wasting much time, I think we will listen to Dr. Ashish. He will be presenting the child. The focus will be mainly on clinical aspects and less aspect on investigations. And I will be pleased to clarify all the issues during your conversation. I will be happy if you can stop then and there and try to clarify all your doubts or clarifications or issues, anything. Dr. Ramesh, are you ready? Yes, sir. You have examined the child completely?
Yes, sir.
Both history taking, clinical examination,
Yes, sir.
discussion, diagnosis, investigations, differential diagnosis, then of course the prognosis, management, everything?
Yes, sir.
I think you can go straight for your final year exam now. Yes, sir. Start.
Yes, sir. Javed Muhammad Ibrahim, a 92-year-old male infant. He was born on 21st of April this year. He is a resident of Bangladesh, and the informant were both parents, and history seems to be quite reliable. The baby was brought here 1 day back with the chief complaints of yellowish discoloration of both the eyes since 14 days of life, and high colored urine which is staining diapers since 14 days of life, abdominal distension since 14 days of life, and pale colored stools since 2 months of life. This baby is a second born baby to the parents, delivered at term with a birth weight of 2.4 kg. Baby was started on direct breastfeeding within half an hour of birth, had passed Makoni within 24 hours. On day 14th of life, the mother noticed both eyes of the baby has yellowish discoloration, and this gradually progressed over the next few weeks, and till the situation where the baby's both eyes look deeply yellowish, and this yellowish discoloration has been persisting till date. And there has been no associated fever, vomiting, lethargy, rash or pallor noticed at the time of yellowish discoloration. On day 14th, mother also noticed that baby started passing high colored urine, which is still in diapers, and it is persisting till now. Mother noticed abdominal distension also, which was not there initially in the 2 weeks of life, and the distension was more in the upper abdomen, more towards the right side, and it gradually progressed till now. And there was no associated complaints of vomiting or non-passage of stool with abdominal distension. No swelling or decreasing in output has been noticed by the mother. And stool color initially used to be brownish yellow, but mother noticed that the intensity of the color has been gradually become lighter and lighter, and by around 2 months of age, baby was passing clearly a depigmented pale stool. There has been no history of excessive irritability, repeated vomiting, lethargy, poor feeding, seizures, hypoglycemic stress, recurrent respiratory infections or oily stool, any bleach, discoloration over the skin, any hematoma following iron vaccination, or bleeding from any other site. Throughout the course of illness, the baby has been very alert, active, was feeding well, and has shown a consistent weight gain, and he is approximately now twice of the birth weight at the age of 3 months.
What is the birth weight?
2.4, sir.
Okay.
This baby was born as a second issue of the non-consanguineous parents, and the mother has been given iron and folic acid during the pregnancy. No other medicine has been taken. Mother was vaccinated for tetanus and under regular antenatal checkups. She has undergone 4 ultrasound during the 9 months of pregnancy. All has been shown to be normal. There is no history of any thyroid disorder in the mother and family, no history of any contact of tuberculosis during the pregnancy or before pregnancy. The baby was delivered at full term by LSCS in view of the previous cesarean section. Birth weight was 2.4 kg. Baby cried well after birth and was started on direct breastfeeding within half an hour of birth. Baby passed meconium within 24 hours. The color of the meconium was greenish yellow, and after the formed stool were passed, which were yellowish brown in color, till the 2 months of life. And postnatally, baby showed a consistent weight gain. The documented weight gain with the parents is around 3.2 kg at 1 month. So baby was showing almost 25 gram per day weight gain during the first month of life. And now baby is around 3 months and the current weight is 4.7 kg, which is almost double the birth weight. Baby has started social smile at around 2 months, neck holding within after 3 months. And currently baby is able to recognize the mother when called. He smiles at mother and able to follow the light and bright objects. Baby has been immunized appropriately as per age. The last vaccine was given at about 2.5 months of age, and regarding the hepatitis vaccine status, parents are not quite sure. And baby has been breastfed exclusively since birth. There are no prelactal feeds were given. Currently baby is able to feed around every 2 to 3 hourly. There has been no complaints of poor feeding and has been passing urines around 6 to 7 times a day. In the family, there is no history of consanguinity. There is no family history of any liver disease, any neonatal jaundice, no family history of any early infantile death, and any or gallstones or contact with tuberculosis. The father is a graduate in the business administration. He runs his own business in Bangladesh. Mother is a postgraduate, and according to modified Kupuswani scales, family belongs to upper middle class. This baby was admitted at 55 days of life in a hospital in Bangladesh in view of persistent yellow discoloration of eyes and pale stools. Some blood investigation has been taken and a scan was done, and parents were informed that the baby is having some infection related to liver and requires further evaluation. So again at 61 days of life, baby was admitted to second hospital where some blood investigation, some scans were done and followed by a liver biopsy. And parents were informed that baby needs surgery. So the parents brought the child to Chennai for the further treatment 1 day back. Currently parents understand that baby is having some chronic problem which is ongoing since 2nd week of life and persisting till 3rd month, and it requires further evaluation and may or may not need a surgery also. So summarizing the details, Javed Muhammad Imran, second born baby to non-consanguineous parents, and there is no significant antenatal or family history, and the baby has been having progressively jaundice since 2nd week of life with high colored urine and pale colored stool, and in the absence of symptoms which are suggestive of sepsis of any metabolic illness, this baby seems to have a neonatal cholestasis syndrome, and it may be probably obstructive pathology which is causing the persistently clay stools since now. I will like to further examine the baby for getting the further details.
Yeah, that's good. You have gone through a good history. I appreciate it. You said he is Imran Khan. I think he is a male infant, you know.
Yes.
What is the significance of sex in cholestatic syndrome? Clinical significance of sex in cholestatic syndrome. What do you want to ask for? Is a boy or a girl?
So the obstructive pathology in neonatal cholestasis, that is extrahepatic biliary atresia and choledochal cyst, they are more commonly seen in female babies compared to male.
Excellent. So, one point that you can always gather when you start investigating, that need not be always the rule of thumb. But if she happens for biliary atresia or choledochal cyst. That's number one. Now, you also said family history. Now, what is the clinical significance of family history in neonatal cholestatic syndrome?
So the baby which are having biliary atresia usually don't have any family history, but the babies who are having neonatal hepatitis, they may have a family history, or there are some familial cholestatic syndromes like progressive familial cholestasis, which
So in a
runs in the
nutshell,
family.
most of the autosomal recessive disorders, whatever that you wanted to say, metabolic,
Metabolic disorders like
or transport
galactosemia,
defects,
tyrosinemia.
so many things may run in sometimes in the family. Okay, right. You have taken a good antenatal history. Can you just highlight the importance of antenatal history in relation to the neonatal cholestatic syndrome?
So one thing in case of torch infections, mother may...
You go in an order. Say for example, if the parents, if the mother maternal history of what you call it as early trimester symptom, maybe you just describe about fever, rash, lymphadenopathy, right, like that, early trimester symptom. Now what does it signify? How does it affect? What manifests, in what way it manifests in the newborn with cholestasis? To get a clue, maternal clues in the history for neonatal cholestatic syndrome in the baby.
If the mother is having,
Trimester findings.
there may be fever with or without rash and lymphadenopathy, which may be suggestive of an infection with a torch group.
That you expect when you take a history in the baby. I agree with you.
We should...
Maternal infections, yes, okay. If it is intrauterine infection coming on, not through the transplacenta. So if it is so, in what way your history will help?
we should know the birth weight of
So
the
I am
baby.
only expanding to imagine. You have started asking about the maternal aspect. I wanted to know history covering the fetal, the neonatal side, patient's viewpoint. How do they manifest?
So this baby may be a preterm or a IUGR baby with a low birth weight.
Right,
The baby may have fever or feeding issues during the early neonatal period,
right,
may have failure to thrive, may
Right.
have some skin rash,
right.
and in some congenital infection baby may have some other systemic malformations,
So
like in...
in one line, the answer could be, to simplify the approach is, if the baby has got some dysmorphism, maybe having a microcephaly, may have a cataract, may have a microphthalma, then probably you will be voting for some intrauterine infection acquired from the mother. That's one thing which you would like to gather information. Agree?
Second thing, yes.
Anything else next in the antenatal history?
If mother is having history of hypothyroidism, then baby should be checked for thyroid status,
Okay.
because it can cause
Anything
thyroid
else?
jaundice.
Anything else in the history?
History of
Suppose if the
tuberculosis,
mother has got intense itching, or if
cholestasis
the
of
mother has got cholestasis, or if the
thyroid.
mother's sister or father, somebody in the family is also antenatally having some cholestasis, what will be the effect on the baby?
So if mother is having antenatal cholestasis, the baby is likely to have a PFIC type 3.
Excellent. So, one clue from the maternal history will be there. Any systemic infection?
Tuberculosis is maybe one possibility, sir.
Okay. Anything else? Suppose if the maternal, if the mother, antenatal mother has got a systemic lupus, what history, in what way it can affect the baby?
Neonatal lupus.
There's some condition called transient cholestasis in the newborn. It will be a transient, right? So that history may be of some use in this people. So some history will definitely say amnia, say for example hypoamnia. Suppose if the baby, if the mother has got delivery which you are not covered in your history. Big placenta, mega placenta. What does it tell you? Maybe the child may be having a neonatal hepatitis. So these are all things which you would like to gather, which will give you what is called a maternal clue for a candidate diagnosis. Agreed? Okay. Now you said about birth weight. What was the birth weight in this child? 2.4.
2.4.
Fine. And it has been sailing through, growth pattern, velocity is fine. Now what is the significance of birth weight and its relation to neonatal cholestasis? Why do you want to note the weight of the baby?
Babies with the torch infection or neonatal hepatitis usually tends to be low birth weight or IUGR, while the babies with biliary atresia, they will usually a term baby with a good birth weight.
Is it always a rule?
No, sir. Even baby with biliary atresia may be low birth weight.
Agreed. Okay. Now what else that you will ask in the history, which will help you to make a definitive diagnosis, which you are not told? Is it not worth whether the baby which is born, which is you have taken a very good history and the child has got a good social smile, the child's growth is normal, sucking is normal, feeding is normal, sleep is normal, everything you have given nicely. But anything else you would like to gather in this history? By and large, if the other baby which you are going to examine may be a different baby, what history will help you? We call two different groups of presentation. One group of presentation is a neonate with cholestasis, maybe a well-looking baby. The other baby is called a ill-looking baby or a sick baby. What we call it a sick neonate with cholestasis. It makes a difference. Now, can you highlight on this difference between a sick neonate with cholestasis and a well-looking neonate with a cholestasis? What is the difference between the two? Why do you want to know this difference? Because you are a clinician. You have to make a clinical diagnosis.
Sir, a well-looking baby with a cholestasis is more likely to have the extrahepatic biliary atresia.
Yes, or choledochal cyst.
Choledochal cyst or
So
surgical.
is it always a rule? Can
No,
a baby be
always.
sick-looking with biliary atresia?
It can be, sir, when baby develops progressive liver disease with cirrhosis.
So a baby with extrahepatic biliary atresia or choledochal cyst with probably a cholangitis, or a baby with superadded infection may become sick. So may not be a hard and fast rule, but by and large, if the baby is a sick neonate with cholestasis,
It's more likely
probably
to
it may
have
be one of these
sepsis
two.
or metabolic, like galactosemia or tyrosemia.
Yeah, what we call it as a sick infant metabolic crisis, they may present with that. Now when will you say the baby is sick? A general question. Dr. SBS may ask you. When will you say the baby is sick with cholestasis? When the baby is lethargic,
Poor
when the
feeding.
baby is hypoactive, when the baby has got an ascites, when the baby has got features of liver cell failure, when the baby is not sucking well, when the baby is throwing out fits, and some clue will definitely tell you that the baby has got a serious illness, you need to see. Can you just highlight some of these babies who are really sick with presentation? What will be the differential diagnosis?
It may be a sepsis or maybe torch infections,
Yes,
galactosemia,
right.
maybe tyrosemia,
What type of sepsis you expect in galactosemia?
gram-negative E. coli sepsis.
E. coli sepsis, right?
It may be hereditary tyrosemia type 1,
Right,
then neonatal hemochromatosis,
right. Alpha-1 antitrypsin deficiency, and much more important is HSV, right?
yes.
That's all you should not forget. Fine, right. So this will definitely help you to note the basic difference, so that you will work up on that line. You will avoid some unnecessary tests which will delay further. Agree? Suppose if a neonate with cholestasis comes with convulsions, what are the differential diagnoses?
Sir, if a neonate with cholestasis comes with convulsion, then
The child is in the ward, emergency room, it has got cholestasis and it throws out a fit. What will be the differential diagnosis?
sir, one possibility is intracranial bleed may be there. Second possibility, their baby might having some metabolic disorder. like glycogen storage disorders, they can have seizure, or tyrosinemia also.
Anything else?
Zell-Weger's
Hyperthermia
syndrome.
can come. Yes, Niemann-Pick's if it is there, yes. So some of
Zell-Weger's,
this neurological involvement may be there. But you mentioned about intracranial hemorrhage.
yes, sir.
So what is the cause for intracranial? Do you mean to say it is likely to be due to coagulopathy?
It
Since you
may-
are committed, I am asking you the question.
it,
Possible? Fine.
possible.
Right. Now what will be the clinical manifestation of coagulopathy in a neonate with cholestasis? So you see the chain of events which is going on. You said intracranial hemorrhage. You said it is likely to be due to coagulopathy. Now what are the other manifestations which will help you in the history that the child is likely to have a coagulopathy?
Sir, either the baby may come with a complaint of a hematoma formation after the intramuscular injection has
You
been
said
given,
vaccination, hematoma, that's one thing.
or there may be
Skin
spontaneous
bleed,
skin or
percutaneous
subcutaneous bleed.
Any other surgery, anything, bleeds,
During putting an
then
IV cannula or surgery may be
fine.
bleeding.
So that will give you an idea whether the patient is likely to see. Now, I have a doubt. You have a child with neonatal hepatitis, with hepatocellular failure like tyrosinemia, galactosemia, hemochromatosis, so many things you described, hemophagocytic syndrome, and then alpha-1 antitrypsin, which we don't see in India because allele is not there, which is a rarity. So these things will definitely you expect some form of a liver dysfunction and coagulopathy. Whereas you have an advanced, probably a biliary atresia, right? Now how do you differentiate whether it is due to biliary atresia with secondary biliary cirrhosis or whether it is due to a liver cell failure secondary to a metabolic cause or an infective cause in the liver? Which one will help you to differentiate these two? Coagulopathy due to intrahepatic liver cell failure versus non-intrahepatic liver cell failure causes. How do you know?
By history we can find out in the biliary atresia, baby will be initially thriving well, may have a low
I have already told. The question is coagulopathy in a given child with neonatal cholestasis, which one test will help you? The answer is you give vitamin K, right? Correctable in extrahepatic. Whereas in most of the liver cell failure with a liver dysfunction, they may not be correctable. Agreed?
Okay.
That's the answer for that. Fine. Now you were given fairly discussable. Now you said it is neonatal cholestatic syndrome. Now when will you say cholestasis?
Any baby was presenting with the clinical symptoms of icterus plus high colored urine and plus minus pale stools.
Good.
We will see
Right.
neonatal cholestasis.
So the necessity for defining cholestasis is you should have a dark colored urine staining the diaper yellow. No. Now what is the reaction which is going on in your mind when you see a yellow urine? It's a conjugated
Conjugated
hyperbilirubinemia.
hyperbilirubinemia.
Agreed?
Agreed.
Right. You also said clinical jaundice. Right. Now, if you allow this cholestasis to continue for a longer time, what will be the consequence? If you don't interfere, you can't give treatment. Something is going on.
So one thing, the components of the bile, which is bile acids, cholesterol, and they will regurgitate into the blood and go
Bile acids, cholesterol, what is the other one?
bilirubin.
Bilirubin. Say first bilirubin. Then talk about bile acids. Then talk about cholesterol. So what do you want to know? The components of the bile components which get accumulated either in the liver or in the extrahepatic tissues. Now what do you want to know about this?
They can explain the clinical manifestation of the.
So you will be on the lookout for some of these clinical manifestations. If the bile gets, if the bilirubin gets accumulated, you will get jaundice.
Jaundice.
And urine is yellow. If the bile acids get, you will get
Pruritus.
pruritus. Suppose if the cholesterol gets accumulated, you will get
Xanthomas.
xanthomas. Particularly when the level is above 600 to 1000, etc. Okay? Right now. You said about bile acids can produce pruritus. Do you know what is the current concept about these cholestatic pruritus? What is the cause?
Previously it was said to be accumulation of bile acids. Now they told because of some
Yeah, bile acid is always there. They get corrected, they get excreted in the skin. That is one of the reasons. The second one?
endopeptides are there, sir, and
Yeah.
metal encaphalins.
Yeah. So you can get something which is released in the gut when the enterohepatic circulation is affected. So that is the one which you can get. Fine, right. Cephalins. Fine. Now the next question I thought I will share with you is, you said about bile acids can produce itching. Now what is the earliest age the child can manifest? There is pruritus or not? How do you? What minimum age? The least age?
5 to 6 months.
Yeah. Floric itching, very good. Hand control, leg control by 6 months? Yes, agreed. Now can a 4-month baby infant like this baby 3+, how can you find out from the history whether there is likely the child is likely to go for a pruritus?
Yes, sir, baby will have excessive irritability or crying.
Irritability, sleepless nights, etc. Now where do you think the child starts itching first in the body? These are all
Yes.
clinical.
Yes, sir.
Yeah, fine. Or by 3 to 4 months they can have leg to leg scratching. These are the two things which we can always find out from this itching and that. Right. Now you said about neonatal cholestatic syndrome. What will be the biochemical support to say that this is likely to be a neonatal cholestatic syndrome? When will you say neonatal cholestatic syndrome? You said about
Clinically when
definition. I told you cholestasis. Now you tell me neonatal cholestasis you said. Now what is the clinical criteria for neonatal cholestatic syndrome?
any baby who is presenting with jaundice and high color during studying diapers and plus minus pale stools is said to be a clinically neonatal
Suppose if
cholestasis.
the child is 2 years, will you call it as neonatal cholestatic? You never gave a age limit now in your definition. The question is not what is cholestasis. You gave a provisional diagnosis at the end of the history that it is neonatal cholestatic syndrome. I am asking you what will be the clinical criteria to say neonatal cholestatic syndrome.
Any infant who has been having proven with cholestasis within first 3 months of life.
First 3 months of life. Even 1 day, 2 days. So ideal will be any child who has got persistent findings for more than 14 days. Right? It may start early, it may start few weeks later, it may start post-neonate, it may start during the infancy. So all these things are included in this basket. So the current view, concept, instead of calling it as neonatal cholestatic syndrome, people prefer to call it as prolonged cholestasis of infants. That is why I just said the onset can be early days, few weeks later, after a month, or during infancy. Right? Now, can you just guess few causes for early days of infancy with cholestasis? Onset I am talking. Intrauterine infection, neonatal hepatitis,
Even
it can start early, and HSV. You can always.
and
right.
there is one variety of biliary atresia,
Yes, yes.
embryonic variety.
The embryonic variety. Yes, agreed, fine. These are the three, you can put it. Onset starts early. What about few weeks? Maybe at the end of, for the ideal critical period for biliary atresia is 10 days to 20 days. That's where many people are likely to overlook, miss, overtreat, undertreat like that. Agreed? So, one is biliary atresia, and most of the metabolic
disorders.
In by and large, most of the metabolic they start little late,
2-3 months.
not maybe 3 weeks, 4 weeks later only. Agreed? But allogerly can present at any age. PFIC can present at any age. Remember that. This is not hot and fast rule, right? Agree. Now the next thing that I thought I will share with you, when you start analyzing these people, what do you think the common causes for neonatal cholestatic syndrome? What is the biochemical criteria for neonatal cholestatic syndrome?
If serum bilirubin is less than 5 milligram per dl, total bilirubin, then direct component should be more than 1.5.
Right.
If total bilirubin is more than 5, then direct component should be more than 20% of the total.
So why do you want to give the cutoff as 5 milligram? From where this funny figure 5 milligram came?
Not sure, sir.
Most often in the neonates, clinical jaundice manifests after 5 milligram. You don't see a clinical jaundice when it is 1 milligram. Agreed? Whereas in older children, beyond neonate, if the total bilirubin is more than 5 milligram, you don't go for what is the concentration, but 20% and above will tell you that it is cholestasis. So the answer is that in a neonate, probably you are likely to overlook if you are looking for 1 milligram. So up to 5 milligram you look for this 1 milligram and above, or 1.5. People even want to, they are able to even look at it even 1 milligram. Fine. Now what do you think the broad groups of neonatal cholestasis which go through your mind when you take a history?
Yes, sir. One is intrahepatic group, one is extrahepatic group.
Okay. What are the common causes for extrahepatic?
Extrahepatic, most common causes is biliary atresia.
Right.
And other than that,
Can you just say what is the incidence? Which one is more? Intrahepatic is more or extrahepatic more? You might have seen last 3 years, you are going for an exam right now.
extrahepatic is more, sir.
Extrahepatic is more. That means you will be sending every child to surgeon. I don't think so. So the majority of patients are intrahepatic. If you take as a group, but if you take as a disease, then categorize all these intrahepatic groups, then that may not be more. The total, if you take intrahepatic, that is more. Whereas biliary atresia comes to around 1/3, 38% as an individual disease. That is most common as an individual disease. But as a group, intrahepatic versus extrahepatic, intrahepatic is more. Among the, now you are talking about this, what are the other causes for extrahepatic biliary obstruction?
The most common one is, sir, biliary atresia.
Then?
Other than that, choledochal cyst,
Right.
and the neonatal sclerosing cholangitis.
Neonatal sclerosis is so commonly seen?
Not.
No. Much more
There
than
may be.
commonly. Which is a closer mimic case of biliary atresia, which will look like almost biliary atresia, and sometimes when they open up and the surgeon say, "Are lovely."
Caroli's disease.
Huh?
Caroli's
No.
disease.
Inspissated.
Inspissated bowel syndrome.
That will almost like, because both are blocking, right? So, anything else? Caroli's you said.
Maybe
Then-
some tumor or some stones, maybe there, sir.
Okay, tumor is little rare. Anything spontaneous perforation
of bile
duct. Agreed. Now where is the perforation occurs in spontaneous perforation of bile duct? It is a junction of cystic duct and the common bile duct. That the most vulnerable site. Agreed. Now, which is the most common finding when you suspect spontaneous perforation of bile duct?
Abdomen discharge.
Big abdomen, ascites. When you tap, you see the bile. Agreed? Right. So now you have some idea about extrahepatic, biliary, atresia, choledochal cyst, inspissated bile, stone something or stricture, and then spontaneous perforation of bile duct, Caroli's, etc. You have finished. Fine, right now. What will be the typical presentation of biliary atresia? Classical presentation in a given case. I always say, fond of telling, what is the clinical triad? The clinical triad of biliary atresia, to save time, is a normal weighted baby, no dysmorphism, lives enjoys the physiological jaundice, then goes for pathological jaundice, dark colored urine staining the diaper yellow, persistent pale stool comes, progressive abdominal distension with a firm liver, and that is the history that's going on. And the urine color is staining the diaper probably at the end of first week or 10th day, and stool becomes persistently pale. The triad is normal weight, normal velocity of growth in the initial period till they develop cirrhosis, no dysmorphism there, and second, they may have high colored urine with dark colored urine, yellow urine, and persistent pale. This is the triad that you normally look for. The support to clinical evidence is a enlarging abdomen,
Liver.
upper abdomen with a firm to hard liver. That's very first you were offered diagnosis till it is proven, otherwise you have to make a diagnosis. Agreed? Now, what can happen in a biliary atresia patient? Can you have a little early onset? You said embryonic type of or fetal type of biliary atresia, you said, which may start by 3rd day of life. Now, why should you know whether it is a embryonic type or a classical type of biliary atresia?
The embryonic variety of biliary atresia have other congenital malformations
Excellent.
associated with.
Because Brahma does lot of mistakes. When he does something there as an embryonic type, other associated anomalies may also come. Now, can you just highlight few other comorbid malformations that can occur along with embryonic type of biliary atresia?
There may be cardiac malformations, dextrocardia, situs inversus. There is some abdominal vascular malformations like preduodenal portal vein or absence of IVC.
Right. I appreciate telling rare things first, but you must always think the common thing. What is very close to this malformation? Spleen.
Polysplenia.
You must always say
Polysplenia.
polysplenia, asplenia, multiple spleniculi, so many things may be there. That you should not. These are malformations. Malformations come next. Okay. So always there is also a syndrome called biliary atresia splenic malformation syndrome, where there is also called even the intravenous cava also may undergo abnormality. We have got a case now in the ward. They have operated. When they opened, they were able to find so many things. So be on the lookout. Now, why should you know? After all, let it be there. 1 plus 1, 1 plus 1, so many abnormalities. Doesn't matter, right? All undergo same more or less the pathology. Now, what is the clinical significance of noting whether it is early or late? Ultimately, the outcome, the prognosis is very poor in all the embryonic type, and failure of the Kasai, so many things, even if you do it before the ideal optimum time, that you may have to do that. So you have some idea right now, right from conception up to this. Agreed? Now, so what do you think this particular child is having right now? Could this be neonatal hepatitis?
Sir, it could have been, but being the history suggestive of a term baby who is thriving well, there is no family or antenatal history suggestive of any torch infections, and a persistent pale stool since the 14th day of life, and in the absence of any dysmorphism or any signs of intrauterine infection, more likely to be in a biliary atresia only.
Anything else more than that? Now I will ask you a question. Two things we normally ask when you analyze a child with intrahepatic cholestasis. One is stigmata of intrauterine infection. The second one is stigmata of inborn error of metabolism. These two things you must always get it in the history. If you have told me no stigmata of intrauterine infection, the examiner will automatically ask you, tell me what is a stigmata. So that makes your way paved towards in favor of you. So now you tell me what will be the stigmata of intrauterine infection that you normally get it in the history. We are still in the history. All our questions are pertaining only to this case. I am not deviating. Yes.
Birth weight,
Yeah.
any skin rash.
So why do you start from? You have taken a very nice antenatal history, but now when I ask you stigmata of intrauterine, Why don't you start there in the history onwards?
Antenatally mother may
Always
having...
history, physical examination, then only investigation. Never go beyond that methodology. In the exam we prepare. I will request you, you will be the most popular pediatrician if you stick on to the clinical aspect. Right? Yes.
Antenatally mother may have history of fever of rash during
Why
first
even
trimester.
before that? What goes on before antenatal? I am not asking you about the college days. What's going on before antenatal? Consanguineous marriage. If the consanguineous marriage is there, it votes probably another inherited disorder, probably it votes for a metabolic.
Metabolic it will.
Agreed. So go in the history, whether to I have asked you two questions, you can answer simultaneously.
Okay.
Fine. Then,
History of consanguinity is there.
yeah,
There may be an history
early
of-
trimester infection in the mother,
Yes.
maybe
And
a
there may be a
feature,
previous abortion
Okay.
or early sibling death may be there.
right?
Or there may be a family history of any other persons
So,
suffering from...
now you mentioned about
Yes.
repeated abortions in the mother and the child has got neonatal cholestasis. What is in favor? Mother has got repeated abortion
metabolic...
and the baby has come with a neonatal cholestasis. You will vote for neonatal hemochromatosis. That is one condition which is popularly given in every book. You have to think about it. Fine. Next.
And then antenatally mother might have fever
What
or
will be the
rash.
clinical stigmata in a given case of intrauterine infection? Multi-system involvement. Small head, or if it is a relatively bigger head, probably toxo. Then
Cataract,
look for cataract,
chorioretinitis may be
fine.
there, sir.
Then
chorioretinitis,
chorioretinitis, yes.
skin rash,
Yes, hepatosplenomegaly, pallor, failure to suck, lax, and then sick looking, right? Buckwheat is small, anything bleeding tendencies easily, and then pallor. Then what is blueberry muffling? Have you heard?
blueberry, yes sir.
You have to rally stigmata of intrauterine infection, that's one thing. It may not be the classical gold standard, but if it is there, you have to appreciate it. What two sides you have look for this blueberry muffling? Lower chest, outer, and knee. They are intradermal bluish nodules. What does it signify? Extra erythropoietic, extra medullary erythropoiesis.
Erythropoiesis,
Right? Maybe an indicator of a CMI.
CMV.
But not always a rule. Great. Fine. Coagulopathy. EC coagulopathy. Always remember intrauterine infection. Agreed? Fine. Now what about metabolic markers? Indicator of metabolic inheritance in a given case of neonatal cholestasis.
Antenatally there may be history of consanguinity or any early sibling death affected.
Right?
And postnatally baby may have recurrent vomiting, lethargy, not feeding well, hypoglycemic spells may be there, or seizures may be there.
Seizures, yeah. Then drowsiness, lethargy you said, right?
It looks like a
And even
sepsis.
sometimes when you look for subtle signs, you need to look for these things. Okay. Oh, what is fine? Mostly history may differ. Now you have made a difference. You also said of the two, intrahepatic versus extrahepatic. Now you tell me which one you are in favor at the end of your history.
Sir, this baby has no history of consanguinity or
Straight away, give me the answer straight away.
it's more
Is it
suggestive of-
biliary or neonatal hepatitis?
should be biliary atresia, sir. More likely to be biliary atresia.
Okay, you think it's more. Is it the classical type?
Classical type, late on, sir.
Okay. Now what age you happen to see?
Usually in the second week,
What age you happen to see this child?
90 days, sir.
90 days. Now are you very happy? The child presented at 14th day of life with cholestasis. Today is 92nd day, almost beyond the scope for surgery, successful Kazai. I am more interested in knowing this is a lesson for everybody who is listening to me. What are all the causes for delay in referral to a tertiary care center or to a surgeon? Why such a delay? We have to answer this in this platform. You all agree with me? This cannot happen to any child. So what are all the causes for delay in referral of a neonatal biliary atresia to a surgeon? Tell me.
Sir, the jaundice will
Probably
usually
would not
be...
have expected this, probably at the end, but we need to know why. In your history diagnosis, I would have been happy not to simply say it is biliary atresia. I need to know whether the child has got any complications of biliary atresia, whether the child would have gone for a cirrhosis, or if there is a delay in Kasai, why? That's what I have asked you the question. Your answer is always make it a point. This child has come to me on 92nd day, though the presentation was at the 14th day of life with considerable delay. That has to be underlined. Why? There is no further delay from your point of view, from your end. So, your history diagnosis should include whether the child has come within the optimum age for surgery or well belated. You agree with me? That's a very good assessment that you have made in the history. You can't make it in a other aspect. So what are the causes for delay in referral?
The jaundice will usually be misdiagnosed as a physiological jaundice of the newborn. And
Is it only physiological jaundice, anything else, or
normally misdiagnosed or misdiagnosed jaundice.
get delayed? That is one. Anything else?
And they will rely on
See, contributors are more, not only one. Anything else? What are the other causes for delay in referral?
will be reassured by the pediatrician that is a physiological jaundice, and keep trying with some other oral medicines which are not really helping.
See, the unawareness to examine these children, whoever has undergone probably a physiological jaundice, phototherapy, etc., he has not asked the people, either a neonatologist or a physician, pediatrician attending, has not asked the child to come for a review anywhere from 10th to 14th day. That is a critical period. That time if he had probably asked whether the diaper stain or anything, at least he should have told the people, yes, if the child has got an yellow urine, please hurry up. That would not have been told, not being practiced everywhere. That is one reason. Anything else? Most of the people are being looked after by so many doctors, they might have given multivitamin. The urine becomes yellow, and the mother complains, my child has got a urine yellow, and the doctor says that will be there because the child is getting a multivitamin. That is another mistake.
Sometimes
And third, telephonic conversation. First immunization day, he would not have cursory examination of a liver, of a urine, diaper. So these are all things which has to be practiced in day-to-day life if you want to be a ethical, popular, ideal pediatrician. We don't want anybody to come nowadays very, very belated information. Agreed? No telephoning, nothing. Sometimes we have seen even cases who come very late. They insist that the child has got a yellow urine. They insist that the stool is white. But still there is a delay. You should not give merit, weight to the complaint and then examine cursory so that you will not make a delay in this. Right. Now, the question is that is it biliary atresia or is it neonatal hepatitis?
is more likely to be biliary atresia.
I don't want to go in depth about, you have already rattled the causes for probably intrahepatic, by and large, so many things, metabolic, the post-TP, and sometimes it may be due to the endocrinopathy, then you get so many things are there, right? Okay, fine now. Now what do you see on, what are the close mimickers for biliary atresia?
The most common
You hold on to biliary atresia in this child.
maybe neonatal hepatitis is the close mimicker, sir.
It's not a close mimicker. You already made a difference easily. Right? It's a differential diagnosis. But close mimicker, where you put what we call as the intrinsic differential diagnosis. Very, very difficult to differentiate sometimes.
Inspissated bile syndrome. Inspissated bile.
The other cause for delay, I tell you, I forgot to tell you. See, if the ultrasound person gives it as a contracted gallbladder, you must always refer the patient for ultrasound in a fasting state at least 4 hours, with or without phenobar, and then see an empty gallbladder, full gallbladder. That's what is more important. So in a already contracted gallbladder, they may give it, you will put it as neonatal. Some ultrasound people even give it as neonatal hepatitis. So that makes the person to postpone further referral. Remember that. Yes, sir. Coming to the mimickers. What are the close mimickers?
Alagille syndrome can mimic, sir.
Alagille, yes, it can mimic, but because that non-syndromic intrahepatic bile duct paucity is one very, very close mimicker, which we cannot make a difference unless you do a liver biopsy.
In early stages,
the second thing, suppose if there is a delay in passage of meconium, and if the child is likely to give a history of an abdominal distension, a meconium plug, meconium peritonitis, etc., probably it may ultimately turn out to be a cystic fibrosis. Not very commonly seen, but you need to bring it here as a differential diagnosis. If you are unlucky, the patient is unlucky, it may turn out to be. That's one thing. Alpha-1 antitrypsin deficiency, not very commonly seen now, but liver biopsy you cannot make a difference. Agree? So some of these things you need to be brought in as a very, very close mimickers. You need to differentiate. Agree? Now what do you see on general examination in this child?
Should I bring the child, sir?
No, you just tell me, then demonstrate the finding.
Sir, on examination, this baby is not a sick looking baby. A baby is deeply icteric.
Give us the positive finding.
Is well alert. This baby is deeply icteric. And there is no dysmorphism. There is no stigmata of intrauterine infections. And in the eyes there is no cataract, no bite. Fundus is normal, there is no choroiditis or no cheratoid spot. On abdominal examination, abdomen looks distended. It's more in the upper abdomen and right quadrant of the upper abdomen. Unlike as a central and inverted, there is no dilated veins. Hypotomy is there, sir. They are 4 cm below the right costal margin in the mid-clavicular line. And consistency is firm and a smooth surface. The spleen is not palpable. And there is no fluid in the abdomen, no ascites. Other systems are normal.
Flanks are not full.
Not full, sir.
Right. Then other systems are normal.
Other systems are normal.
Right. What else you should have seen now? You can take in a history. Of course, if you don't do, doesn't matter. But you have to tell me I have not done it, sir. No, I will straight away put yes, examiner's question. You say that the motion is pale. You say the urine is dark yellow. Now there are 3 ways of demonstrating that there is cholestasis clinically. What are the 3 ways? Clinical demonstration of cholestasis, what are the 3 ways?
One is icterus, sir, which is clearly visible in the baby.
Okay.
Second is high colored urine.
That icterus may be even conjugated or unconjugated, or it may be a mixed form. Right?
Urine and stool color you have to look for.
Stool color you have to look for.
Yes.
You should have told the examiner, me at least, sir, though history is in favor of a persistent pale stool, I have not seen the stool now. What else you can do in the exam hall. What is RST? Rectal swab test. You take an earbud, put a little xylocaine or liquid paraffin and stimulate the rectum and see the motion on the spot. That's always better. The second test people may ask you, though we don't do, but Japanese believe in that, is a 24-hour duodenal aspirate for bile. Second. And they may also look for cholesterol crystals there. The third one is said but not practiced, for if you are writing a theory fine, is endoscopic duodenal papilla. If it trickles bile, probably that rules out biliary atresia. So these are the three ways of naked eye examination of bile. Wherever possible we can see. Agreed? Now, the question is, sometimes the mother may say, my child is passing pale yellow motion. What do we call it as? You are getting confused sometimes. Whether it is really pale or whether it is ecolic stool or pale yellow stool, varieties may come. Now how do you solve this issue?
Take the stool in a container and put them in a white surface.
The answer is, you need to examine the motion for 3 consecutive days. That should be the first answer. Never go with one. Right. Second, if the child has got a very high bilirubin, dark colored urine, the question comes only for an ambiguous color of the motion, whether it is yellowish, pale or pale yellow or ecolic. So in this situation, when the bilirubin is very high, conjugated bilirubin is, if it is more than 10 to 15 milligram%, the entire body is yellow. It stains even the intestinal mucosa. So the mucosa is shed once in 6 days. So along with this pale motion, if the pigmented mucosa gets covered over that, and that can coat the ecolic stool, and you may get an ambiguous look. It may give an ambiguous color. The mother may say it is pale yellow. Sir, it is only yellow. You need to examine this motion because that's the deciding point. How to solve this issue? Either you can cut the motion, see the core which is always pale, white, clay color, or you can wash it. It will, the outer covering coat will go off. That's another way. But whatever may be, this ambiguous should not be the reason for postponing
Referral.
the diagnosis. If you are in doubt, or if your referral doctor is in doubt, always tell them ambiguous stool is one of the indications for referral to a tertiary care. That should be the message. Agreed? We don't want any further delay. Now, you examine the child, right?
Yes, sir.
Now, what do you think? Now, after examination, after history, your provisional diagnosis now. You want to give one diagnosis or 2 or 3 diagnoses?
I want to give a DDs 2 or 3.
You want to give a DD. Okay. Then?
Most probably it is an extrahepatic biliary atresia without any features
So
of
first
cirrhosis.
diagnosis?
Yes, sir.
Right. Second diagnosis?
Second, sir, it can be a initial stage of PFIC, PFIC. We cannot rule out by history.
Right. Then?
And it can be
Why are you not telling non-syndromic intrahepatic
paucity of bile duct.
paucity?
Yes, sir.
That can come second. Then PFIC usually by 3 months plus may present with itching, and PFIC can come with, to start with, intermittent. It need not be a completely ecolic stool. So you need to be an antenatal history, does not help you. and there are no family history or SIB history of PFIC in the family, so a lot of points against, so you will push it down in the low order priority. Okay, fine. Any one of you would like to offer any other differential diagnosis here? Fine. Now how do you approach now? Any complication did you look for in this child?
We have to look for the complications of liver's failure or cirrhosis.
What is the natural course of biliary atresia? Right from start to the end. Untreated biliary atresia.
So initially they will start with jaundice and high colored urine, but otherwise baby will be thriving well. Over a period of time, if left untreated, then they will develop cirrhosis and with secondary complications of liver failure like ascites, coagulopathy, and they will convert into...
You are right. The best way to put it the naturally is to start with you get some bile duct inflammation. That inflammation itself can have a functional block. So you get the cholestasis. Then the cholestasis, if it is not relieved, they go for fibrosis. That is, you know, it's a fibrosing, necrotizing cholangiopathy. Exact etiology people are doubtful. They may even blame virus, reovirus, enterovirus, adenovirus, echovirus, so many things, CMIV. But they are all comorbid, but that's not the proof. Or it could be autoimmune. They are not proven. Or this could be probably occurring more when there is a genetic predisposition. That's the current concept in this. Now when it goes on, some inflammation is going on, fibrosis is going on, block is there, they present as neonatal cholestasis, and persistence of cholestasis has become a chronic cholestasis. It has become a chronic liver disease. So when the bile is bent up, you get toxic bile acids accumulate, you get secondary biliary cirrhosis. If then you don't treat, they go for complications, and finally they go for what is called end stage liver disease. That is the natural course. Agreed? Now, in your finding, are you able to find anything that is in favor of any of the complications? The child never had a Tori stroke. The child never had GI bleed. But I beg to differ from you. The child has got a tipped spleen which is masked by the huge liver, and the measurement I would like you to examine again. How do you examine the abdomen in this child? How do you examine the abdomen in this child? There is a question to you.
So keep the baby supine in the mother's lap. And then first an inspection, whether any distension of the abdomen is there, or any rash or incision or scar mark is there. Flanks are free in this particular baby. And on palpation, abdomen is soft and non-tender. Liver I am able to palpate.
Yeah, then?
But spleen palpates.
You started with the right upper quadrant distension, right? But now you are not telling anything about the distension in the examination of the abdomen.
Yes, sir, abdomen is distended, sir. It's more of upper abdomen.
Upper abdomen.
Flanks are
So
free.
if the upper abdomen is distended, naturally we expect the umbilicus to be pushed down. But you said it is central. It becomes, findings are paradoxical. Salam. Keep the baby there. Yes, sir. Show me the. You said the umbilicus is central. Is it central or pushed down? Don't worry. central, this is the xiphoid process, this is the pubic symphysis. It has been pushed down to 1/3. It's a common finding which most of the postgraduates, I wish all the postgraduates come and see. If there is an inspection finding of an upper abdominal distension, automatically the umbilicus has to be pushed down. If it is a ovarian cyst, the umbilicus has to be pushed up. This is basic medicine. Agreed? Do you agree? Fine. Then it is 2/3 versus almost 3/4 versus 1/4. Umbilicus, the shape, everything is normal. Agreed. Then what else do you see here? Which you never mentioned in your finding. Agreed? So there is a divarication of the recti. Right. Then anything else? There are very few slender veins you are able to see here. Agreed? This is slender vein, probably due to the stretching. Now the divarication is very clearly seen. Flanks are free. Right. Okay. Then now how do you examine this abdomen in this baby? Cha-cha, cha-cha, cha-cha. I am doing something. What is this procedure called? To make the child more comfortable. It will be doctor friendly. What is this procedure called? Pawing. It's called PAWING. Pawing is the procedure which you make the patient more friendly, very cooperative, confident. They will have more faith in you. Right? Fine. Right. Okay, ma. Thank you. Thank you. Thank you. Right. Now, how do you examine the abdomen? Where will you start? Palpation. Palpation of the abdomen. No, don't worry about it. You will always tip. Fine. Then? No, palpation. No, you just tell me. That's enough.
I want to start from right leg.
Right? Right leg fossa. Fine. You start right leg fossa or left leg fossa? This is something basic you must see. You start right or left? You start from, you don't start in the right. Palpation is given, you must start from left lower quadrant, left lumbar, spleen, epigastric and liver, and then this, it is anti-clockwise, which is an ASCII question for you. Agreed? You must read. Okay, doesn't matter, right. So, you according to you, the liver is 4. Please, I will keep the finger here. You see the lower border, tell me. It is better in these people with liver disease, particularly chronic, you give the measurement in the right midclavicular line as well as in the midline, so that one of the indicators of chronic liver disease is an isolated left lobe enlargement. So for that you may be missing. That's why better to give. And what you are doing is poking. You should not poke the liver. You must go along with phases of respiration. This will not take so much time. So all firm livers will be better appreciated by cupping method. Wait. By cupping method you can appreciate the firm liver if it is a sharp edged liver, right? So it is almost coming down to the right iliac fossa, and this is 4 centimeter or longer than. We have measured, it was 7 centimeter. 7 centimeter in the right midclavicular line and 6 centimeter in the midline, sharp edge 4, and spleen is tipped. Spleen is tipped. Agreed? Now why? In which condition? I am going to put you now the differential diagnosis. Okay. you can take the child. I will come and discuss with you later. Agreed? Fine. So most of the people, please start examining, and nobody can help you in the exam hall. You need to examine and then go ahead. Now, the question now is, what does it signify if the child has got a firm liver, large, big hepatomegaly in this child?
So chronic process is ongoing.
Chronic process. You can have a soft liver even in chronic process. For example, if the child has got a fatty liver, fatty acid oxidation defect, right? Acyltransferase deficiency. If the child has got a large firm liver, it undergoes, already the child has got significant fibrosis. So it's an ideal candidate to go for cirrhosis at any time. That small liver, spleen that is seen, I do not know, may be turned out to be a part of the portal hypertension to start with. Why? That's why this particular child, you must cross your finger. Alright. So, you need to know about that first. Second most important thing in here is, now which type of splenohepatomegaly is seen in cholestatic liver disease, neonatal cholestasis. This is a hepatosplenomegaly. Which type of neonatal cholestasis, the spleen is more than the liver?
When the liver gets cirrhotic, then it's possible, sir.
That is an advanced one. Yeah. That is an advanced one. Niemann-Pick's, all lipoid storage disease. Hemophagocytic syndrome, you can have, right? Can we see the, now somebody wanted to know, could it be sickle cell disease? What is your answer now?
Sickle cell disease, first thing, if the baby is having this much size of liver and spleen, but there is no anemia, first thing, there is nothing history suggestive of hemolysis, and baby has clear cut pale color restored with a dark urine, that is not supposed to be there in sickle cell disease.
Oh, I think, have you got the answer, sir? The reason my friend says that there is no anemia, what else you said?
Pale color stone.
And it is a complete cholestasis to start with.
And which is persistent.
Right. Are they related marriages? Consanguineous marriage?
Non-consanguineous.
Non-consanguineous. Fine, right. Okay, then. Now how are you going to proceed now? Rapid test. What we call it as candidate diagnostic test. This is called. That particular candidate, what diagnosis test you will like to do, and tell me why. Rapid, yeah.
First we have to do the stool examination, sir, whether it's a clinical stool persisting.
You would like to stool examination, I am repeatedly telling you, I will examine for 3 days. Already it is crossed the limit for surgery, time limit. So better to do for 3 days, right? Ambiguous stool, you will not miss. Then
serum bilirubin fractionation I want to do, to see whether the direct component is high or not.
Right.
Once I am sure that it's a cholestasis.
Do you expect any abnormality here? The child has got a deep jaundice, the child has got a yellow urine, the child has got pale stool, still the blood test is going to help you now? That's for completion's sake, right? So you will always finish off in everything in the basic test to satisfy your inclusion criteria. But I am asking you, you said it is biliary atresia. The question is, what is the candidate diagnosis?
GGT, sir.
What test that you are going to do for biliary atresia?
GGT I would like to look for.
GGT, right? That's the one gold standard single test which will always tell you it is likely to be both SAP and cholestatic enzyme you will do. Fine. If it is satisfied and if the conjugated fraction is very high, you are happy. No. How do you know that it is biliary atresia?
In biliary atresia, sir, GGT and SAP both should be.
No, don't go on beating about the bush only with biochemical.
Then I will do the fasting ultrasound next to sir.
Fasting ultrasound. Yeah, tell me something detailed about how you are in charge of the case. You are sending the patient for ultrasound. What instruction you will give it to the staff nurse?
Baby should not be given any feed for the 4 hours before the scan is being done.
My child is very hungry. It goes on crying. What are you going to do? You want to start IV?
4 hours we don't need really.
We normally give them glucose water. Our ultrasoundologist feel that one dose of glucose water can be given, or at least quench the thirst with plain water and try to manage. But you don't give milk and milk products, right? Just 4 hours minimum. Okay, anything else? What do you look for?
In the fasting ultrasound, first we look for
What will be the triad of ultrasound finding in biliary atresia?
decogenic liver.
Look for liver first.
With a contracted
Will you go for liver first? In biliary atresia?
gallbladder we will look for, sir.
Huh?
A contracted or absent gallbladder may be there.
Contracted or absent gallbladder. Okay.
And
You are sending the patient for ultrasound in a suspected biliary atresia. Why should the gallbladder be contracted? That means you are sending the patient with milk.
in biliary atresia, sir, the bile will not be coming down to the gallbladder.
Yeah.
There will be
It's an
obstruction to the
absent gallbladder or non-visualized gallbladder.
non-visualized gallbladder.
That is what you are looking for. Agreed? So, contracted gallbladder is the one which is one of the causes for delay in referral. Remember that. Agreed? In contrast, if you are able to see a well-designed gallbladder which is more than 1.9 millimeter in length, and when you give milk, if it contracts very well, contractile gallbladder that is called, that probably excludes biliary atresia, but not always the rule. That's one. What else you see?
Then we should look for other etiologies like choledochal cyst.
No, I am not able. I want triad of ultrasound finding in biliary atresia. One, you said you will look at the gallbladder which is usually absent. Second,
Intrahepatic bile ducts. Intrahepatic biliary duct dilation.
intrahepatic bile duct. What do you see in intrahepatic bile duct? Dilated? Array.
In complete biliary atresia, sir, it may be dilated.
Dilated. I'm sorry, sir. You don't look for the bile ducts are usually atretic. It's a dynamic process. It's not a static disease. So you don't look for dilatation usually. Right? Maybe suboptimal size, but it's not dilated usually. Right? If it is dilated, probably you need to rule out. The dilatation occurs proximal to the biliary atresia, particularly in type 1. You may form a cyst, that's all, but you are getting confused with that. So, what you look for is a gallbladder absent or present for practical purposes. Till you pass, you remember that only. What is the second? What is triangular Koch sign? Triangular Koch sign is a cone-shaped echogenic area in front of the hilum,
Hilum of the liver.
between the division of the portal vein. What they normally look for specifically for triangular Koch sign, the diameter should be more than 4 millimeter in front of the right branch of the portal vein, anterior to the right branch of the portal vein. You look for that. That is the second one. This is enough if you see. Some examiners may ask you, what is ghost triad? ghost triad is more sensitive but not very specific, least specific. But if it is there, it helps you to make a good diagnosis of biliary atresia. What do they look for? The longitudinal diameter of the gallbladder is more than 1.9 millimeter, 1.9 centimeter, and then the
Inner mucosa should not be smooth.
mucosa is not well formed, irregular, and the gallbladder itself is irregular shape. That's called ghost triad.
Ghost triad.
But it is mainly for some examiners but not for all. Right. Echogenicity of the liver only tells you whether there is any increasing fibrosis.
Fibrosis.
Minimal fluid can be picked out if it is going to be cirrhosis. Choledochal cyst is a kindergarten diagnosis for an ultrasonologist, which you can very well make a diagnosis. Stone can be picked out. Preduodenal vein can also be picked out. Situs inversus can be picked out. Right-sided pleural effusion can be picked out. So these are all the evidences which will help you in that. But still, what is the, I'll come to that little later about this, don't worry about the sensitivity, specificity of each test, but ultrasound is the first test that you normally do to screen this, whether there is cirrhosis or not, etc., biliary atresia, it will help you. What is the next step you wanted to do?
If ultrasound is also suggestive of biliary atresia,
Okay.
along with the clinical history, I would directly like to go for a laparotomy with the perioperative cholangiogram. But if ultrasound is creating a doubt with our clinical history examination, then I will, before going to laparotomy, I will like to get further.
What is the role of HIDA scan or hepatobiliary scintigraph? What is the role?
The HIDA scan is
The option is given to you, you say, I have made a clinical diagnosis, ultrasound says it is likely to be biliary, so I will straight away without delay, I will send it. Right? But now what is the role of...
Sir, HIDA scan actually we give a radionuclide and we see the uptake by the hepatocytes and then followed by the biliary excretion. So in case of a hepatitis, the uptake will be delayed because hepatocytes are damaged, but once the uptake is there, it will come out till the duodenum. So we can see the dye is coming in the intestine.
Okay, the test is there, patient is here. Will you use the test for this child? That is the question. I am not asking you what is HIDA. You are explaining what you do in HIDA. But I am asking you what is the clinical relevance of when will you use HIDA in a patient with biliary atresia or neonatal cholestasis. I will use it when there is an ambiguous stool. I have made a clinical diagnosis of biliary atresia. Ultrasound is equivocal. I am not able to guess. Many may not pick out triangular sign. So in those situations, I may use this to see that. But even then, there are limitations which you need to consider. What are the limitations of HIDA? Number one, if the stool is persistently failed for more than 14 days, I will not do a HIDA. Why? The isotope will not come to intestine. If the conjugated bilirubin is very high, or if there is going to be a mixed hyperbilirubinemia with hyperbilirubinemia, if the total bili is more than 25, if both are very very high, probably I may have a sick liver. It may not even uptake
also.
It may not excrete. It's a two-in-one test. It takes the isotope, releases. That's why I may not use it. False positives are more time consuming. Not everywhere it is available. Costly. Sometimes in an ambiguous, I may have to give Gardinol or ursodeoxycholic acid up to 30 milligram per kg per day in 2 or 3 repeated doses for at least 5 days. Then I will see whether it comes out. So it's a time prolonging. I am delaying. That is why many people would like to bypass HIDA scan. Agreed? So I will request all of you to make a note of considering the limitations which are more than the actual indication for asking for HIDA. What about liver biopsy?
Liver biopsy is more definitive compared to HIDA, sir. But liver biopsy in biliary atresia will be little different picture from neonatal hepatitis. In biliary atresia we see...
No. The question is, I am not asking you what will be the finding. The question is, will you consider liver biopsy in this child? Or you want straight away?
We like to straight away go for the laparotomy and hepatic angiogram, sir.
No, you want to do a liver biopsy. The
Because-
child has already gone beyond the scope for surgery.
Yes, sir.
It is already 92 days. What is there to wait for some more day? Agreed? What is the urgency? Already there is a belated. So what will be what is the indication for liver biopsy in these people? We have trained our liver biopsy pathologists adequately, who will give you the report in maximum 24 to 48 hours.
First thing, if the baby has come to us earlier, when we are having a time limit for delaying the surgery,
So if
then
the
we can
baby is
consider.
well in operable state, and if your clinical diagnosis is biliary atresia, ultrasound is in favor, nothing wrong in doing the biopsy, confirm it and then give it to them. Why? The reason is
We can,
you will avoid a negative laparotomy. It is an invasive procedure. If you want to advise the mother, I will open up, it's not that easy to convince
Yes, sir.
and counsel them. So to avoid that negative laparotomy, you can always say which the sensitivity specificity goes up to 97%. That is the reason liver biopsy is still next to the gold standard. You can always do within a day. What do you expect in this child? What will be the liver biopsy finding in biliary atresia? The three important findings. One, ductular proliferation. Second, significant fibrosis.
fibrosis and inflammation.
That means widening of the portal tract, periportal fibrosis. And third most important thing is bile
Bile
plugs
leaks.
or bile leaks. These are the three that you normally see. You can see some giant cells, but they are not very significant. In contrast, what do you see in neonatal hepatitis?
There will be no bile proliferation or very minimal,
Right?
and there will be inflammatory infiltrates, and more of giant cell hepatitis we can say.
Giant cells,
With
yes.
hepatocytes, focal necrosis and volume
Right?
of
Anything else that
hepatocytes.
you see? So it is significant fibrosis. What you call it is that it's a diffuse change. It's a panlobular diffuse change that you see in these people.
And the basic hepatic
Fibrosis is
architecture also
relatively
will be
less.
altered.
That's what you look for, right? Fine, right. Now, some etiology you can always find out by doing a liver biopsy. We will not go into that later. So, the place for liver biopsy is always there. You can always do if the patient is well within the, suppose if they come to you by anywhere from 28 days to 45 days, you can always do and then go ahead. We will get the report in maximum 48 hours. That's not a big thing, though it's an invasive procedure. Particularly if the patient is not willing for you have to convince them, right? So what do you do? What is the gold standard test now at your disposal for this particular child?
Laparotomy with a perioperative cholangiogram, sir.
Laparotomy, and have you seen perioperative cholangiogram on the table?
No.
How do they do? What do you achieve? It's a 4-in-1 test. What is that? First of all, they open and then see the gallbladder,
Gallbladder.
whether it is atretic or not. Second, they look at open the lesser omentum. Lesser omentum is also called gastrohepatic omentum or lesser sac. They open up and try to find the portal
Portal vein.
tract. So in that portal tract, they try to look for the bile duct.
Bile duct.
So bile duct, whether it is atretic or not. If the common bile duct is atretic, it is type 1. It's not a good one for operation.
Operation.
Then proximal systems are normal. Then they go little above and look for the
Common hepatic duct.
common hepatic duct. And if the common hepatic duct is obliterated, common bile duct is obliterated, cystic duct is obliterated, then you call it as type 2, not a good case for surgery. These are the two. Normally when you see, the gallbladder may not be seen in the ultrasound. Then near the hilum, you have the right and left hepatic ducts, right? If they become atretic, the gallbladder also may not be seen, and that is the type 3. So the examiner may ask you, why do you want to know the type of biliary atresia? Correctable or not correctable? Type 3 is the most commonest, 95%, and that is more correct, not correctable. Agreed?
Agreed.
Right. So most of the, what happened? Going for confusion. Which one? Correctable. Proximal. So they would like to go for
Proximal should be not correctable.
No, right, proximal. The portoenterostomy is Kasai procedure is usually done in type 3.
Type 3.
And they try to pour out everything and see that bile pours out. They use a lens and then do the procedure. Now there is one more type, don't worry about it. So perioperative cholangiogram is a 4-in-1 test. What they normally do, they try to put in a catheter into the gallbladder, inject the radio opaque material, the films are kept, plates are kept, it is a screening done there, and then they try to inject and see whether the bile is coming from through the gallbladder, the same route, the radio opaque material is coming into the intestine. That will give you the patency of common bile duct. Then they clamp it and try to re-inject, go whether the proximal area, they try to send the thing. So this is usually done to find out whether it is operable, not operable, whether what type it is, they will find out, and ultimately. Then you can take a wedge biopsy of the liver. You will have a naked eye examination of the liver whether it is cirrhotic or not, and do a Kasai procedure. Great. Now, what is the ideal time for doing a Kasai procedure?
So if we do it early within the 60 days of life, the outcome is good. If we do is maybe up to 90 days of life, the outcome is poor compared to the earlier surgery.
So ideal will be as early as possible. It is much more called as a surgical emergency. Right from 28th day up to 60 days, people allow. I normally say that don't wait for the 60 days. A pediatrician has been given more than 1 month for making a diagnosis. Do you want that?
No.
Why do you want to wait for 60 days? You have to do it well beforehand. Before 45 days, the success of surgery is phenomenal. Agreed? Right. Now, what are the complications that you expect in the post-Kasai?
Post-Kasai, surgery get recurrent episode of cholangitis.
Yes, cholangitis, ascending cholangitis.
Then you have progressively worsening of cholestasis.
Yes.
If they are not able to establish the exact bile flow,
Right.
there may be progressive cholestasis.
Yes.
And then can develop into chronic liver disease.
Decompensation, cirrhosis,
This cirrhosis
is going on advanced.
And then complications of cirrhosis,
etc.
total hypertension,
Fine, right,
ascites and bleeding.
Fine, right. Now, what determines the success of surgery in a person in Kasai procedure? What decides? The triad.
What's the age of the baby, sir, what the operation has been done?
Time of surgery, when you do, is 1. Second,
Second, whether bile flow could be established or not at the time of surgery.
okay.
And third is the size of the biliary, intrahepatic biliary ducts. That size, the remnants of the biliary ducts, the size also provides a
Okay,
prognosis.
these 3 things you have already told. One is the type of the presentation. Second is the age, the time of the surgery. The third most important, the experience of the surgeon. That's a very important thing. Otherwise it becomes an exercise to the surgeon. Right? So that's what is more important. Okay, right. Now complications you say. Now before as well as later in a child with biliary atresia, how do you take care of the nutrition of the child?
Sir, because they are not able to digest the fat, they will...
Don't explain, you are not writing theory.
So we
You
should...
just say 1, 2, 3, 4,
So we should
5.
give them the high calorie intake, maybe up to 150 to 200 kilocalorie per kg per day. Along with
150
this,
to 100.
150 to 200.
Usually given 200
And
calories, and how much of protein you give?
medium chain
2
triglycerides.
grams of
we can-
protein. Exclusive breastfeeding should be continued, and then medium chain triglycerides wherever
and
necessary.
we can supplement.
Fine, right. What about vitamins?
Vitamins, especially the fat soluble vitamins A, D, E, K, they should be supplemented. And along with that, the water soluble vitamin should be given in the double the requirement.
That
required dose.
cannot digest, there's going to be malabsorption, and you feel that oral may not be of much use.
Then we can
Probably you need to go
supplement
for parenteral.
parental vitamin A,
Vitamin A, vitamin D,
D, and
vitamin
K.
A, and then calcium, phosphorus, you
phosphorus,
refer the
magnesium,
dose.
zinc.
Agreed, magnesium, iron,
Yes,
all should be
zinc.
continued. Medium chain triglycerides. Okay? Right. Now, child has come back after Kasai. You are the primary physician. How will you take care of the post-Kasai follow?
We should monitor the color of stool, color of urine,
Periodical checkup you will
checkups,
do,
clinical checkups,
Yes.
when baby's weight gain has been
looking
given.
for reduction in intensity of
Intensity of
jaundice,
jaundice.
clearance of jaundice. That's one of the features of this, and maybe pale stool, and then complications, cholangitis postponement. How do you postpone cholangitis in a given child? You need to give a long-term biliary antibiotics. What antibiotic of choice?
Cefotaxime.
Antibiotic of choice in a child with post-Kasai procedure. If there is going to be a sepsis, probably amoxicillin aminoglycosides or
Cefotaxime aminoglycosides.
cefotaxime or ceftazidime. Some people even give quinolones. Earlier people have been using even rifampicin. Okay, doesn't matter. So that can be given. Otherwise, long term, the first or second generation cephalosporins can be given, cefixime or cepodum can be given to these people for a long term basis. Maybe at least for 6 to 9 months you need to give to postpone the episode. If the patient comes with a cholangitis, as revealed by depth of jaundice increases, pale stool has come back, dark urine has come back, deep jaundice, abdomen becomes distended, tender, looks toxic, high grade fever, you need to admit and give an antibiotic for at least 14 days, and you need to do a blood culture, urine culture, septicemia workup, etc. has to be done for these people, right? Now some of our patients may come with itching. Pruritus. What are the anti-pruritic, cholestatic pruritus drugs?
We also do oxalic acid UDC.
What is the dose?
20 to 30 mg per kg per
20
day.
to 30 mg per kg per day in 2 or 3 divided doses you can give. Okay, any other drug?
We can use
You can mention the drug name, you can refer the dose.
yes, sir.
Cholestyramine, cholestyramine can be given.
Cholestyramine, we can use
Phenobarbital can be given.
Phenobarbital, even steroid can be given.
Ondansetron can be given. Rifaximin can be given. Then
Steroid can be given.
go in for steroid. Nobody gives steroid. That was the old school of thought. They said edema can come down, but nobody gives steroid now in a post-Kasai procedure. Yeah.
Phenobarbital.
In our hospital,
Phenobarbital.
we have done a project, but that was a failure. Nobody is giving now. No steroid. Right. Then
Phenobarbital can be given, sir.
phenobarbital, yes. Anything else? Naloxone, nalmefene, IV. With that plasmapheresis, then you go ahead with propofol. Then the last, ileal bypass, and finally the child is 4 years, 3 years, or even older, and then has got a intense pruritus, almost suiciding tendency, advanced liver disease. Probably you have to go in for liver transplant. Agreed? Right. Now what about vaccination in these people? Post-Kasai or post-transplant?
Post-Kasai, sir,
Mother is anxious to know what vaccine I have to give.
DPT should not be given initial few days of post-Kasai, sir.
Why?
If they come back with a fever, they may create a confusion between cholangitis.
That's not a big thing. Nobody can make a, it's not a big difference. Just because the child had a post-Kasai and I will not give a DPT, it's cruel. No. All vaccinations are permitted for these people, provided there are no other conditioning factors, contraindication for the vaccine. All the people beyond 1 year of age should receive vitamin A. The hepatitis A. The death rate is very high if they develop hepatitis A.
And hepatitis
You
B
need to
should be
give.
given.
And all transplant
Hepatitis B.
people should not give live vaccine.
Live vaccines.
This is a must for these people. Agreed? So, are you really happy about a baby coming very late here?
Not really, sir.
You have to counsel. So, what is your plan now? What are you going to do for our patient?
This baby first, sir, needs to go for a confirmatory diagnosis, and once it is confirmed, baby has to undergo Kasai's procedure. For that,
See, if I remember correct, they have already done most of the tests in these people. So they have done an MRCP. I don't think that it has helped us. They have done a liver biopsy. The report has come as neonatal hepatitis. What does it mean? Clinically you have made, ultrasound wise you have made, and now liver biopsy person has given. That means he is not a good pediatric hepatologist, hepatopathologist. So you need to give it to a better person and see the smear by yourself, slide. Otherwise you need to repeat it, probably that will be the best. But the child is already crossed the age for
92 days.
Kasai, 92 days. So why do you want to do a liver biopsy right now? Again. The best way is, open liver biopsy will be better. You submit the child for a perioperative angiogram if you really want to confirm, because the child has come from Bangladesh. The child has to go with specific diagnosis. That is the reason the child has come. So the problem here in this issue is, in this baby is, the child not only suffers from the disease, but also suffers from diagnosis. That's why you need to go for perioperative angiogram, which we have planned tomorrow, and probably we will come back to you. If anybody is interested in knowing, we will give you the finding of perioperative angiogram in this child. I think what did we learn today at the end?
So first,
Our focus is not to talk about everything that causes the neonatal cholestasis. This discussion is pertaining to the particular child who has been referred to you. And we have had A to Z. If we remember, probably what we have done is right. No. Have you learnt anything now?
yes, sir. No.
Agreed?
Agreed, sir.
Thank you. Thank you so much for all the listeners. Not much of question. Right. Agreed. Oh, questions are there. Wait. We'll try to answer this question. Sir, how long does it take for conjugated bilirubin to rise in biliary atresia above pathologically significant levels of 20% of the total? It's a good question. It all depends upon the amount of inflammation that is going on before you start examining. This 20% is the time that when you make a clinical diagnosis. Agreed? Which may be missed earlier. It is a question that depends upon how long the inflammation is going on inside and what is the type of biliary atresia you have, and finally the comorbid disorders that you are going to face in this child. That is the one which is going to decide. So it depends upon the half-life of bilirubin, and most probably what is deciding the 20% and above is the passage of the bile through the biliary passage. There are many factors operating here. It is very difficult to answer how long this 20% comes. But the 20% is the cutoff for giving a clinical diagnosis. After how many days post-Kasai procedure we can expect regular colored stools for counseling the point of view. It all depends upon whether you are able to strike at the bile. If you are able to corrode, if you are able to get the bile out, you can see that everything is clearing off. Maybe it will take about 2 weeks to 3 weeks. Role of steroids in post-Kasai biliary atresia we have already answered, no role. Any screening procedure to detect neonatal cholestasis as early as possible in 14 days of life. Probably the thyroid screening you can do, infection screening you can do, metabolic screening you can do. Unfortunately, most of the metabolic screenings, this is not going to be of use. Why? Even biliary atresia, all the clinical, the histopathological finding cannot be demonstrated unless the child goes beyond 4 weeks. Even allogyny cannot be diagnosed. Bile duct paucity cannot be diagnosed before 4 weeks. That's why you need to do the biopsy after 4 weeks. Nobody does. Biliary atresia also, nobody does the biopsy within so week because the finding may not be correct. The answer for that is, of course, screening procedures we have told. What is the role of ERCP and MRCP we have already told. The observer error, the costs and the cost effective ratio is not very much appreciated and we are not doing it. But it can be done in particularly in choledochal cyst if that has been missed. And could it be sickle disease? We have already answered. Unlikely. Thank you. Right? Thank you, Bob. Findings? Okay. You need to? ஒரு பவுன் போட்டேன் நடுவில் அதுதான் போறப்ப வந்துச்சு பரவாயில்லையா port will go off, that's another way. But whatever may be